Hello, guys. We are going to speak today about hypersensitivity pneumonitis because you know that in August we published the last international guidelines of HP. So you have here the publication we made in the 1st of August, and you can see we were about 42 authors. To know how we deal with all these guides, we make a revision of the literature made by ATS representatives, and after we make a contributions to look for more publication or more papers. So after some months we make a meeting in Dallas, and after once again we write a new draft, and the author we collaborate to try to improve this draft. Afterward, after some more interventions, we make a meeting in Boston in November 19, and from there it was written a draft, and we try to improve once again this draft, and finally the manuscript was finished, and we sent to American Journal of Respiratory Disease, and the journal sent to the referees, and after this we answer point by point, to the referees, no? And this is the final guide we publish, no? Well, which is the definition we make? The definition of HP is it's an inflammatory and or fibrotic disease. This is the new classification, only inflammatory and fibrotic, and of the lung parenchyma, and also the bronchi, no? the small bronchi. It is typically mediated, immunologic mediated reaction, and that comes from a known antigen, or not known sometimes, in the susceptible individuals. So you must have a genetic characteristic to have the disease. Well, the symptoms is like ever: dyspnea, cough, fever, and chirping rails in the auscultation. And in the high resolution CT, we can have the non-fibrotic form, that is the typical ground glass and hyperlucent areas, no, making a mosaic, no, or can be a little the mosaic, the ground glass can be stronger, and it is the non-fibrotic form, no. The ground glass have more density. And finally, we have the other form, that is the fibrotic form that we know, I think, very well, with honeycombing, in the periphery and downstairs. Well, here I have the figures that we published, and you can see in the A figure you have a centrilobular pattern, nodular centrilobular pattern, that is very characteristic of acute form, no? Also the mosaic, the B. In C, do you have the air trapping, and in more exaggerate, because in the expiratory scan. And in the D, we have the ground glass opacity, here with cyst. That is very characteristic. In some patients has only cyst. That is a very rare form, but you can find it. And you have the E, you have the reticulation, no, on the periphery, and a point of this figure, you have a small airways disease also in the periphery, no? In the G, you have a fibrosis in the upper zone, but you can have the fibrosis also in the middle or central, here with some peribronchovascular inflammation. And finally, you have in I, you have the fibrotic ground glass figure with these characteristics, hyperlucent areas, little areas. No? Well, even you can find something that is characteristics of hypersensitivity pneumonitis in high resolution CT. That is the tree density pattern, no? That has been called heat cheese pattern, no? You know, and you can find in the same high resolution CT you can have ground glass, you can have lucent areas, and you can have normal lung. Well, if you go to the pathologic characteristics, I think we know there are not many things, new things. But do you have in the figure A, the poorly formed granulomas? You have here 2 granulomas. And in B, these granulomas sometimes have cholesterol crystals. No? It's quite characteristic, but not pathognomonic. No? And also in C, you have the same granuloma with the Schaumann bodies. No? These are obscure substances. That is also characteristic, but not pathognomonic. And in D, do you have the typical, very well formed and very different granulomas of sarcoidosis. This is sarcoidosis that you can see, and we know all that is very different from hypersensitivity pneumonitis. Well, which is the classification we made in these guidelines? So the subacute form is eliminated, and we just have the non-fibrotic pattern. It is inflammatory, and the fibrotic pattern, no? Of fibrotic form. No? And well, in the fibrotic form, as you know very well, the survival is limited, is reduced, and it's also reduced if you have a reduced FEV1, FEVC, sorry, or BAL, poor lymphocyte in BAL, persistent. If you don't retire the antigen, you have persistent exposure. Probably you go worse. And if you don't identify the antigen, it has been published that the prognostic is worse. And also we know outside of this guideline that the survival is reduced in the older age if you have a lower DLCO, or if you have a high resolution CT with a UIP pattern. No? Well, what is the epidemiology of the HP? It is said in the literature it's about the incidence is about 0.5 to 0.9 per 100,000 patients, individuals, sorry. We have published now, I think it's in press, in the archives of bronchopneumology, and we find that in our area of 5,100 people, the incidence was 4.9 per 100 during 10 years. So it means that our incidence in Barcelona, in our area, is 0.5 for 100,000. No? So it's very, very near the what it has been published, but our incidence is only for bird-breeder disease. So we find a little more than this is established. Well, besides are the inciting agents, we know all that the feeders coming from birds or feeders coming from duvet, with feeder duvet, or we find usually fungus, no? And you have the fungus in the walls, or you have fungus in material, or fungus stored in the warehouse, no? With some vegetables or some. Well, and you also can have with humidifiers at home, or spa. These substance aerosolized, no, with fungus or not. Here in the right of the slide, you have the classification, all the circumstances, and you can give you HP. And we publish, it's the same list that we publish in 217 in the American Review with Wasakova and Ganesh Raghu, and you can find there, no? It's a list of about 70 different causes of HP. Well, which is the pathogenesis of HP? What we know that is immunological dysregulation, no? And you can have an exaggeration of humoral mediated immunology, and also cellular mediated immunology is one of the possibilities to have all this inflammation of HP. Do you see? We published in 1983 that the cellular is important in HP, so it's very long time. And the other thing is that the Th1 can switch to Th2 and conduct or lead the normal path to fibrosis, fibroblastic activity, and lead and finish with fibrosis. Well, how we diagnose the HP? It's sometimes the acute form is easy, no problem we have, because we know the antigen, and we can very quick we made the diagnosis. The problem is with fibrotic form, no, and so we try to identify the antigen, so the exposure is very important, and in the literature is only finding about 50%, so it's we don't find very many antigen causes, no. So the symptoms, we have auscultation with Velcro rails or chirping rails, these inspiratory rails, no. So we have the high resolution CT that we have commented, the pulmonary function, the detection of IgG antibodies, mostly against birds and fungi, and we always made the bronchoscopy with BAL to find lymphocytes, and we usually in our home we usually make always cryobiopsy in this form, no? And also we make inhalation test. The inhalation test is not very well seated in these guidelines. Only seated because to identify antigen. We use in our home, in our center, we use for diagnosing, and we find that is very useful, but we don't always convince everybody. Absolutely. And you have here above in the right of the slide this publication where we try to convince people that it's not necessary to make a surgical line biopsy. No? With all other battery, you may for sure make the diagnosis without the biopsy. And this is something that in the other side of Atlantic is not so clear. They sometimes they need biopsy to be sure that that isn't HP. Well, the diagnosis criteria in these guidelines is based in three points mostly. Knowing affected agent, this is important criteria to diagnose hypersensitivity pneumonitis, a typical CT, and a typical biopsy. But we say we don't want to make a biopsy if it's possible. No? Open lung biopsy, cryobiopsy we made. And the third tripod, is BAL lymphocyte. So it is important, and nowadays the guidelines recommend to make always the BAL, because it is a good point to diagnose pneumonitis. Also, we make a specific IgG, and if it is a female, it's most probably a little bit at least. And and usually you know that HP is a disease of non-smokers people. No. Well, we make an algorithm. You know that always is difficult to follow an algorithm, but we make this algorithm based in these three characteristics, these three points, no, this tripod. One is exposure, high resolution CT, and lymphocyte BAL. No? So you have a patient. If you have the tree that is in the left of the slide, you can be sure that is a HP. Always, it's necessary to discussion with pathologists and with radiologists. They help us very much to make the diagnosis. No? And in the right column, if you have only two characteristics, so afterwards probably you must do it some cryobiopsy to be sure of the diagnosis. No, this is the resume of this table. We perform, or we make another table that is this one, and that I find a really very complicated table. It is based also in the tripod we have spoke until now. So I think that it is impossible to explain now or to follow. I think that patient by patient one can look this table and more or less to confirm the diagnosis. But I can say that to perform this table, it was a lot of discussion, and there was a consensus, but no, it's not so clear, the diagnosis. No. Well, which is the histopathological features of non-fibrotic cellular? Do you know the three characteristics are interstitial pneumonia, bronchocentric, if it's possible, chronic bronchiolitis. The bronchiolitis is typical of HP, and granulomas. If you have these three, the diagnosis is absolutely sure. Sometimes we found foamy granulomas that are characteristic and means that the obstruction of the bronchiole. If you have only one or two of these three characteristics, so the diagnosis will be probably only, you know. And if you have only one or two and nothing more, we can say that the diagnosis will be indeterminate, so we are not sure. Sometimes in the biopsy you can find the peribronchial metaplasia that is not pathognomonic of this disease, but if you find it is something in favor, or expansion of fibrosis inside the alveolar septa, or you have focus of organism pneumonia. All it helps to diagnose. In the fibrotic form, the typical finding is fibrosis, subpleural fibrosis, and also centriacinar fibrosis with bridging or without bridging to the septa. No? And in this feature, in chronic fibrosis, you can find features of UIP or non-specific interstitial pneumonia, or you can find, once again, bronchiolar metaplasia, or if you find isolated giant cells, all is in favor of diagnosis. But it sometimes is difficult to diagnose hypersensitivity pneumonitis if the fibrosis is very extensive. No? Well, which are in concrete the committee recommendations? In the questionnaire, have you some questionnaire to use, and it's not any questionnaire validate, so we don't make any recommendation after review 32 publication articles. About the IgG antibodies, the committee recognized that has some a high sensitivity and specificity diagnosis, but we only suggest to perform these antigens, these IgG antibodies. We perform always, no, as of course, no, but it was suggest to perform. BAL was 84 articles selected and studied, and the committee suggests to perform. About the transbronchial, is not recommended in fibrotic HP, not recommended. And cryobiopsy, we review 34 antigens, and the committee in non-fibrotic we don't recommend anything. You know, we're not sure about the recommendation. And in fibrotic form, we suggest to perform. I told you that we perform always. You know. In surgical lung biopsy, we review 34 articles also, and in non-fibrotic and fibrotic, we just suggest, and we suggest to perform after making all the diagnosis procedures, and probably we can avoid to make surgical lung biopsy for diagnosis. I think it is a good message if it's possible not to make a surgical lung biopsy. No? Well, that's all what I have to say for today. You see this slide is a slide from nice city, Barcelona, the same as Lisbon or Porto. I've been there also. And thank you very much for your attention.